I bring greetings from Mohit Bariatrics and Robotics Surgery Center, Indore, India. I am Dr. Vinny Mathur, the Bariatric Program Manager. And let me again welcome you all to the 5th episode of Virtual Bariatric University. This time, we're here to discuss about Roux-en-y gastric bypass. Is there a standard? I have with me some great and accomplished leaders in the field who have immense experience to help us navigate through some difficult questions. Is gastric bypass really the gold standard? What is the relevance of gastric bypass as a procedure in the era of sleeve and mini bypasses? I have this honor to introduce you all to our stellar group of faculties who are here with us to discuss the topic. Let me first introduce you to Dr. Teresa Lamasters. She leads a very busy, successful practice at Unity Point Clinic in West Des Moines, Iowa. She has performed over 3,000 bariatric surgeries in the past 13 plus years. Dr. Lamasters currently serves as a Secretary Treasurer for the Executive Council for the ASMBS and will proceed on to serve as the President of ASMBS in 2022. Dr. Lamasters has been a course director and invited expert speaker for numerous local, national, and international events. I welcome Dr. Teresa. Then we have with us Dr. Frits Berends, whose research team has focused on the basic aspects of Roux-en-y gastric bypass design and how it can be improved in the recent years. He was the founder and one of the directors of the Vitalis Obesity Center, a high-volume bariatric clinic in the Netherlands, performing more than 1,300 bariatric procedures a year. He's in the board of directors of the Dutch Society for Metabolic and Bariatric Surgery and the chairman of the Dutch Guideline Community on Surgical Treatment of Obesity. He was also the principal investigator in many studies and publications on the treatment of obesity. He has presented articles and has given lectures all over the world. I welcome Dr. Frits Berends. This evening, we have Dr. C.C. Wang. Professor Wang started performing metabolic and bariatric surgery in China 2000, becoming the first surgeon to perform the laparoscopic Roux-en-y gastric bypass in mainland China. He was the founder of the Chinese Society for Metabolic and Bariatric Surgeries. He is also the editor-in-chief of Chinese Journal of Obesity and Metabolic Diseases. We also have with us Dr. Nilton Kawahar. He is the assistant professor of general surgery at the Hospital das Clínicas of University of São Paulo. He is also the member of the Brazilian Society of Bariatric Surgery. He was the founder member of the Brazilian Society of Laparoscopic Surgery, and he also was the coordinator and creator of the Bariatric Endoscopic Surgical Trends Symposia. I'm honored to introduce Dr. Rafael Alvarez Cordero. He is the co-founder of the International Federation for the Surgery of Obesity 1995. He was the founder and honorary president of the Mexican College of Surgery for Obesity and Related Disorders. He was also the IFSO president from 2007 to 2008. He has extensively published in the field of bariatric and metabolic surgery. Now we have with us Dr. Ramen Goel. He is the bariatric and metabolic surgeon in Wockhardt Group of Hospitals, Mumbai, India. He is the president at the IAGS. He is the chairman in the scientific committee of WCES 2024. He is also the associate editor of the Journal of Minimal Access Surgery and editorial board member of the Indian Journal of Surgeons. Dr. Fobi and Dr. Bhandari are our co-directors of the course. So without much ado, let me now call upon the chairs for the first session, Dr. Ramen Goel and Dr. C.C. Wang.
Hi, good evening, friends. So I think let's take the program forwards, and I welcome our speaker, the first speaker, Dr. Teresa Lamasters. Vinny has been kind enough to introduce her. I believe she has done her fellowship in bariatric surgery from Stanford University and was the first surgeon to do gastric bypass in Iowa and also robotic surgeries in Iowa, and did the first standalone sleeve gastrectomy in Iowa. She has been doing revisional surgeries and sleeve gastrectomies and Roux-en-y gastric bypass. So I welcome Dr. Teresa to start her presentation.
Great, thank you so much. I'm going to share my screen here. All right, so thank you so much for your kind introduction. Thank you, Dr. Fobi, Dr. Matar, and the organizers of this conference for inviting me today. As you mentioned, I am from Iowa. I'm going to share a little bit about that, but I'm going to be talking about an interesting topic today. So I'm going to kick off today about talking a little bit about gastric bypass in the US and kind of the evolution and different variations of that. These are my disclosures. It should not affect my talk today. And this is where I live and practice. I live in Iowa, which is in the middle of the United States, and in Des Moines, Iowa, which is in the very middle of Iowa. My office is in West Des Moines, which is a suburb, and then my hospital is downtown. It's a level 1 trauma center, major tertiary care center. So I have to make one correction from the introduction. I was not the first surgeon in Iowa to do the Roux-en-y gastric bypass. Iowa is one of the birthplaces, actually, of bariatric surgery. So there are many giants who've come before me. But I was one of the very first surgeons to use the Da Vinci platform here, and also especially I brought sleeve gastrectomy actually to Iowa. So that was a first, but bypasses have been here long before I have been here. So I'm going to talk a little bit about variations of the gastric bypass and where we're going for the future. I really think the title of this talk could be Variations on a Theme. I will tell you that our history is very rich and interesting in bariatric surgery. It has required great thinkers with creative problem solving. Essentially, all the pioneers, and Dr. Fobi was in that group as well, looking at this deadly, debilitating disease with really little understanding of the underlying disease and trying to treat this and save people's lives. So the initial target was really, how do we decrease the number of calories coming in? And trying to create an anatomy that can't be overcome by behavior choices. And then having basically anatomic changes that would force behavior changes. So the goals for treatment of obesity seem kind of obvious. We want durable weight loss, elimination of comorbidities, prevention of future comorbidities, improved quality of life, and extended years of life, especially decreased mortality. But I would suggest we're going a step further. We're looking for really a pure metabolic procedure with the lowest negative side effects. And we know by far surgery is the most effective long-term treatment for this disease of morbid obesity and its related comorbidities. But there are so many options for surgical treatment of obesity. These are the most common options in the US. We still have the lap band. Not a lot of are placed right now, but there are many, many patients that still need care with the lap band. We have the sleeve gastrectomy, which is king. We have the Roux-en-y gastric bypass, still a classic, still strong. The biliopancreatic diversion with duodenal switch is really a small percentage. And then the SADIE-S procedure is starting to gain some ground and interest as well, but still not a high percentage. There are other variations, though, of the gastric bypass, and these are done in limited amounts in the US, and we're going to talk a little bit about these. But variations of the limb lengths for the what's called standard gastric bypass. We have the one anastomosis gastric bypass. We have the banded gastric bypass. But again, why are there so many options? And it really comes out of a drive because all the current options are imperfect. We're still trying to find the best outcomes for the lowest risk. And we know that if we pull on a lever on one side, another lever moves on another side. And sometimes those unintended consequences can be pretty negative. So what are the current shortcomings of the gastric bypass? Where did all these variations come from? Well, we found that, that we want durable weight loss, and there can be weight loss failure or weight regain. And now the terms we use are understanding better that not everybody responds the same to the same treatment. So we think of it more as partial responders or non-responders, but there's really no consensus around a definition of what is true, quote, failure or true non-response from a procedure. Some of the early definitions, such as defined as if they still have a BMI greater than 35, whether they lost and regained or they never reached lower than 35, or excess weight loss less than 50%, and recurrent metabolic syndrome. So if we use that criteria alone, anywhere from 15 to 35% of patients after gastric bypass will meet that criteria. How I describe this to my patients is 1 out of 10 people will gain back most or all of their weight. 2 out of 10 will gain back some significant amount of weight. 7 won't gain back significant amount, but 9 out of 10 are better off than if they didn't have surgery. We know that the gastric bypass has shortcomings. It's been a classic standard, gold standard procedure for a long time, but we know it has some downsides too. And as surgeons, we accept these, but there's a risk of marginal ulcer. There's definitely some malabsorption and risk for micronutrient deficiency. It also alters some medications in the amount that is absorbed. There's risk for internal hernia, dumping syndrome, bowel gas, bowel changes, and just some intermittent abdominal pain that can happen actually fairly frequently, and some Roux-stasis syndrome. So essentially it comes down to, we're looking for a better mousetrap. We're trying to get better. When we're not satisfied with the weight loss or the weight regain or with the return of comorbidities or the negative expected side effects, because we don't really even necessarily think of those so much as complications as those are expected side effects. Many of the variations that come are driven by looking for improvement in those areas. So we're usually either chasing more restriction or more malabsorption or both. And that's definitely been the initial thinking from the beginning. And then when we when we found an unintended consequence or a negative consequence, then we modified things and tried again. This has kind of been the approach in the past. So these are the targets. And I know a lot of people are going to talk about these individual components, but we can look at the pouch. You know, the pouch used to be big, then we went to this super micro pouch, and now that's changing again. We looked at the outlet, the gastrojejunostomy. We looked at a band over the bypass to force restriction, keep it from expanding. Then we looked at the bowel limb lengths. Can we make the roux limb longer? How about the biliopancreatic limb? What about the common channel, the distal part, where all the food and enzymes and bile mixed together? We know that if we make that shorter, we definitely have better weight loss, but we also comes at a cost of more nutritional problems. So I'll tell you that this is kind of where the standard Roux-en-y gastric bypass exists in the US, but there are lots of variations. The biliopancreatic limb, and this certainly when I trained, and it's getting to be a while ago, the biliopancreatic limb was actually kept pretty short, 20 to 40 centimeters. The roux limb was usually between 100 to 150 centimeters, and the gastric pouch was made small. And that got smaller and smaller, especially the time I was training. It was becoming from a 6 centimeter pouch down to a 3 centimeter pouch, and even smaller, just these little micro pouches. The gastrojejunostomy, lots of different ways to create that, lots of different sizes for that anastomosis. 21, 25 millimeter, hand sewn, linear stapled. Lots of roots of the roux limb, and lots of ways to create the jejunostomy. And that was the standard, and we can see how much variation is there already. Well, then some people started looking at the roux limb and looking at something called a long limb gastric bypass. And essentially this is looking at extending that roux limb a little bit longer. And the idea is that when the food and nutrients contact the roux limb, they're not really fully absorbed until they interact with the enzymes and the bile. So making the roux limb longer should help increase malabsorption. And this also essentially overall shortened the common channel by lengthening the roux limb, because they kept the biliopancreatic limb, the arm of the Y over there, the same. So then some people weren't very happy with those results. So then we came into, well, what if we distalize the bypass? And so that means basically having the roux limb stay shorter, but the biliopancreatic limb get longer, so that the roux limb encounters the biliopancreatic limb further along. And this is, I think, a very good article reviewing these changes with Dr. Gyasi, Dr. Di Maria, certainly this Keith Boone and Higa's group as well. So again, longer biliopancreatic limb joining the common channel lower. And this is where they start introducing this term of TAL, or total alimentary limb length. And for fellows, for trainees, trying to get your brain around that concept, I think is going to be important. This procedure has evolved as well. In their initial experience, they kept that common channel and the total elementary limb length actually quite short. Then they found that they needed to reverse some of those patients, so they extended the length. And now the target's usually keeping the total elementary length around 400 to 450 centimeters to avoid the significant protein calorie malnutrition. The mechanism's probably related to the distal delivery of nutrients that alters the incretin, the signaling pathways, and bile acid pathways. So this is just a little bit of a review of their paper. They looked at 96 patients, and the first 11 had the shorter version of tall, and then the next 85 had the longer version. And they found that this was for revisions of weight regain usually. And they were able to decrease the BMI between 6 to 8 points with 40 to 65% of excess weight loss, excellent metabolic control of disease. Complication rate was about 6.3% with reoperation rate of 5% if they didn't include those original people who needed the limb lengthening. So with that together, that would be over 12.5%. But they found over 20% had significant hypoalbuminemia at 3 years, and the calcium metabolism was significantly worsened compared to the standard gastric bypass. And so they really felt that even though there were 7 randomized control trials out at that time on different limb lengths, changing the Roux limb, changing the BP limb, the common channel, it wasn't clear which of those factors were independent or dependent, and it wasn't clear really which direction we should be going. So then we look at another variation, and this has become very popular internationally, the one anastomosis gastric bypass. And this was the ASMBS review that's fairly recent, 2018 is when this was published. And in the United States, most surgeons are less familiar with this. It's all gone by the name of mini gastric bypass as well, but essentially the differences are that it's a longer gastric pouch, but narrow, usually 10 to 12 centimeters. And then a loop for the gastrojejunectomy, not a Roux limb. And then this afferent limb can be different limb lengths, but most choose about 200 centimeters from the ligament of Treitz for the afferent limb, some even smaller than that. So with the loop gastric bypass and the narrow gastric pouch, it has a little different profile than the standard Roux-en-y construction. There looks to be possibly a lower risk of internal hernia with that loop construction versus the Roux. Also less risk of what's called Roux stasis syndrome and bowel dysmotility that's directly related to the reconnection of that Roux reconstruction. Potentially less risk of marginal ulcer. Not necessarily clear if it's any weight loss advantage. There appears to be some early, but not necessarily later. And then most techniques would be really similar endpoint to a distalized Roux-en-y gastric bypass, but it's without the Roux-en-y configuration. There is some discussion of the risk of bile reflux because of the loop configuration impacting the stomach and potential esophagus with an unknown risk of malignancy. So kind of pros, cons of the one anastomosis gastric bypass, and I'm sure somebody else is going to talk about this in more detail, so I'm just going to give brief overviews. It's a shorter operative time. There's only one anastomosis instead of 2. The early complication rates are pretty comparable to the Roux-en-y gastric bypass and very favorable overall. It's a good metabolic procedure. It treats type 2 diabetes well, hypertension, hypercholesterolemia. We're not entirely sure about the risk of bile reflux with the loop gastrostomy. It's been reported different areas, and really it's a matter of getting enough patients far enough out with enough monitoring to really nail this down. But the concern in the US is there are many surgeons who their hesitation is the risk of malignant changes of the stomach or esophagus related to bile reflux potential. Now, some studies actually show a higher percent excess weight loss with one anastomosis gastric bypass, and others say it's really comparable, especially by the time you get out a little further, out to 5 years. What about the band over bypass or the banded bypass? Now, we happen to have one of the pioneers of this procedure call today, so I'm sure he'll get a chance to talk about this. But this is looking at the fact that whatever procedures we do that we're relying on restriction, that restriction declines over time. The stomach is a soft-sided organ. It is not a concrete, hard-sided organ. So there's always some loss of initial restriction in procedures. So this was an idea of putting a band over the pouch to decrease how much accommodation there was. But when it's also combined with distalization, then it may impact how much the protein the patient can eat, and that may impact the protein calorie malnutrition. So what we think for the laparoscopic adjustable gastric band is we think that's probably related to a vagal mediated pathway of satiety and appetite suppression and a smaller component of restriction. We don't know if that's the same mechanism related to a band over a bypass or not. So Dr. Fobi did publish on this actually several times about, combining a band with a bypass. And this is kind of a diagram of how he initially did it and then kind of how it's done today. Very good initial weight loss and maintained that through the first 3 to 5 years. As all of us struggle with follow-up, the follow-up started to decrease, especially around that 6-year mark. So it's harder to say for the longer-term follow-up. Of the patients who followed up, there was excellent maintaining of percent excess weight loss, but it's a smaller percent that followed up. At the time this was published, a complication rate was very similar to the Roux-en-y gastric bypass without a band. The difference being an addition of risk of band erosion, which overall was about 2.5%, but good metabolic disease treatment. And the best results were in patients with a BMI of 40 or lower. So I'm going to go through this a little bit faster because I'm running out of time here. But this was a combination of actually band over bypass with some distalization as well, which had a good decrease in BMI, similar to other distalization studies, but had a little more protein calorie malnutrition. And that could have, again, been due to limiting the patient's ability to take in high protein foods, possibly. Dr. Schauer's group also published on band over bypass, and they felt that it was safe and reasonable and may help with extending the weight loss longer. So it really comes down to looking to help keep that initial restriction present. So this article I strongly recommend everybody look at. This is very new. It's actually just coming out here, but it really digs into some of the mechanisms of action of different bariatric procedures. And it really looks at the Roux-en-y gastric bypass and the sleeve gastrectomy very specifically, and digs in at a much deeper level than restriction and malabsorption, and understanding the gut hormones, the neurotransmitters, the pathways that we're using. It talks about both sleeve and bypass impact metabolic disease, but they actually do this through very different mechanisms. And really, it has almost nothing to do with restriction. And it really has a lot to do with the gut hormone signaling. There are important receptors that are involved. The FXR, the TGR5 receptor, has a lot to do with bile acid receptors, and the gut microbiome is altered. And the interesting thing is it looks like it's altered differently for a patient with a bypass compared with a sleeve. So this is very, very interesting stuff and truly the future. So I tell you, in the US, we have a drift from the standard bypass now. People are starting to experiment with some of these different things all in one, but they're still calling it the standard bypass. I would tell you most surgeons have extended their biliopancreatic limb now, anywhere from 50 centimeters to 100 centimeters. Most people keep the Roux limb at least 100 centimeters because there was some good data that came out from Dr. Higa's group that if you're under 100 centimeters, frequently when they had to do a revision for recurrent marginal ulcers, they found that Roux limb was actually about 60 to 65 centimeters when they did the revision. But in the op note, it was always documented longer. So keeping it longer to decrease the risk of marginal ulcer or bile reflux, they felt was important. Small gastric pouch volume. This has changed a lot. I would tell you more surgeons are getting away from the little micro pouches to longer, narrow pouches, closer to what you see with the one anastomosis gastric bypass, actually. The gastrojejunostomy, people are much less focused on the size of that gastrojejunostomy being extremely precise. That, in fact, they think that if it's too tight, they develop maladaptive eating behaviors and actually have more weight regain. There's many roots of the Roux limb. The jejunostomy still has lots of variation. And there's increasing interest in sati. So where are we going in the future? We're starting to understand better that physiology drives behavior, and that bariatric surgery works really primarily through alterations of gut hormones and neurotransmitters rather than the components of restriction and malabsorption. Those are actually playing smaller roles. And we have hopefully a better idea of how to select patients. As we get further in the future, this is really going to help us select patients about what's the right procedure for them. And understanding that obesity actually isn't the same in all people who suffer with a disease. The phenotype of obesity on the outside doesn't mean that it's the same on the inside for every person. So the successful treatment of chronic diseases requires lifelong regular outpatient follow-up visits, vitamin, mineral supplements, lab evaluations, and a multidisciplinary approach. In the future, we need to pay more attention to racial disparities, social determinants of health, and also consider even, in the DiMaria study, they had super selective criteria for their patients, extensive pre-op preparation, and even then, they found that most patients don't follow up after 3 years. So if we're going to do hypoabsorptive procedures that need extensive follow-up and vitamin mineral replacement, we need to understand the reality of today that patients in the US don't follow up well. So we have to think about that when we're choosing a procedure with a patient. What's the risk of self-harm if they don't follow the rules? The other thing we have in the US that can be different from other places in the world is the general medical community doesn't understand the disease of obesity well. They definitely don't understand bariatric procedures or the potential downsides. And so we do not have a robust medical specialty that lines in parallel with our specialty. So like transplant surgery has nephrology that's right along parallel with their specialty. We just don't have that in the US yet. So to wrap it up, there are always trade-offs. You can't get something for nothing. So we have to understand that. We have to look for the right balance and have a holistic approach. What's the best thing for this patient in front of me today? So in conclusion, there's many variations on a theme. Obesity is very complex. It's a heterogeneous disease. And as we better understand the mechanisms of change that are induced by the surgeries we're doing, then we can further refine and tailor the approach to the individual patient. So thank you so much for forward to our discussion.
Rafael?
Dr. Raman, you have to unmute yourself.
I think Dr. Cordero.
Yes, I'm very pleased to see this excellent presentation for two reasons. First, it is a great pleasure to celebrate 100 years of our master and teacher of we all. And to see Dr. Lamasters is from that area. Second, it is a pleasure to have Fobi, whom I was able to meet for the first time 50 years ago. I consider this very important. There is a basic difference between any surgeon or any specialty and bariatric surgeon, and that's this. Any surgeon tries to correct any problem of the patient, such as broken bone or something like this, while obesity surgeon try to disrupt the normal anatomy in order to get another result. And so that is one of the reasons of we have this excellent results, but some other problems that we have been resolving as the time goes by. Congratulations.
Thank you. You have any questions, Ramen?
Yeah, Dr. Teresa, extensive review of literature and the various variations. I would be interested in knowing this, because what we are seeing is that while the MGB surgeons are reducing the lengths of their bypass, the Roux-en-y gastric bypass surgeons are increasing the length of their biliopancreatic limb. What is a standard Roux-en-y gastric procedure in your hands? What is the pouch size? What is the BP limb size? And what is the Roux limb?
Sure. So I can tell you my procedure has evolved over time, just like I think everybody has. So my pouch is a little longer than I used to make it. It's now about 6 centimeters in length, but very narrow. I size it over about a 36 to 40 bougie size, French bougie size. So it's narrow, but it is a little bit longer. My biliopancreatic limb is now 60 to 80. If I'm a higher BMI patient, it's closer to 80. And then my Roux limb is usually between 100 and 150, again, depending on BMI. So I had an interesting experience. My former partner used to do a very, very long biliopancreatic limb and a short Roux limb. And we had some interesting results. Is the first 2 years, his weight loss was better, but then after that, the weight loss wasn't better. But what we found is a higher incidence of small intestinal bacterial overgrowth in the long BP limb, essentially. And he had a much higher marginal ulcer rate, but he was making his Roux limb fairly short at 60 centimeters. So it was an interesting perspective just in our practice when we had two different techniques to look at. His weight loss was better in the first 2 years, but then that effect disappeared. And then we got some other trade-offs. Just like we said, we can't get something for nothing. So then we had some other things to take care of on those folks.
Yeah. So do you think that prolonging the pouch is a necessity if you are going to increase the BP limb? Because when you have a 15 ml pouch, you cannot afford to have a long BP limb. So you are trying to compensate that by increasing the pouch size so that if there is a malabsorption, that is taken care with increased eating.
Exactly. And I think when we're looking at conversions of sleeves to other procedures, we have to think about that, because the original, even Sadie procedure, those were much wider sleeves than what we make a standard sleeve today. And so they were able to accommodate more volume intake. So I think you do have to make that adjustment and understand that you can't have both on both sides, or you'll end up with too much protein calorie malnutrition too. Micronutrients are easier to replace overall, but if the patient can eat appropriate foods, that actually helps. Instead of eating just what we call slider foods, or foods that dissolve very easily, they tend to be high calorie, low nutrient foods. So we want them to eat the right kinds of foods. So you're exactly right. So accommodating a little bit this way to get a little more of the bile acid impact actually related to the BP limb being longer.
Yeah, I think that's a very valid point, because most of the people take one takeaway message that, we should have a longer BP limb without realizing that the person has done a longer pouch or a bigger pouch so that the person can eat a little more. So thank you so much for such a wonderful talk. Thank you.
Could I ask you something about it? Because I don't understand why you couldn't have both. Why couldn't you combine a longer pouch with a longer BP limb? What's the problem then?
You can combine a longer pouch with a longer BP limb works. But if you have a short little micro pouch and a longer BP limb, they usually can't eat enough high protein foods to maintain their protein intake. So I don't have that little micro pouch that I used to have.
I don't fully understand, because the length of your BP limb is irrelevant in your protein uptake, or am I wrong there?
It's irrelevant for the protein intake of how much they are able to eat. Am I maybe not answering the question right? So
to elucidate that, it's exactly what we're doing. We're making a long pouch, even longer than you, Teresa. We're making a pouch of at least 10 to 12 centimeters and combine that with a long biliopancreatic limb, and then put a band around it. That's
okay. Yeah, that's okay. But if you make a really small pouch,
I agree on the long pouch, yes, but I didn't see quite why you couldn't combine that with a long BP limb, because that's very sensitive.
You can.
Yeah, okay.
But not, I guess what I think Dr. Goel was trying to point out too is that if you have a very small pouch and a long BP limb, you're going to run into protein calorie malnutrition.
I disagree. I don't think so. They don't. Both are irrelevant as to absorption of proteins. It's your toll, like you mentioned correctly, which is combined the length of your alimentary limb and your common channel, but it's totally apart from the pouch length or your BP length.
Teresa, Teresa, may I have a question?
Yeah.
Don't you think it's very important to measure the whole small bowel? Because in the anatomic human, we have a variation from 3 meters
Exactly.
to 12 meters, right? And since
Absolutely.
2010, I measured the whole small bowel, and I found from 4 meters to 10 meters. We know 40% of the small bowel is jejunum, and the 60% is ileum. If we have 4 meters, we have 160 centimeters of jejunum. If we have 6 meters, we have 240 centimeters of jejunum. But if we have 10 meters, we have 400 centimeters of jejunum. It's totally different if you will have intestinal bypass. So I do in my patients the proportional intestinal bypass. What do you think about that?
So I agree 100% that there's huge variation in how much small bowel length there is. And for me, it's more that you have adequate common channel. That's the real key. And I would err on the longer side of a common channel length. And then from there, it's not going to be the same for every patient. But I think when you really delve into the mechanisms of what's going on and how it's actually working, that variation is okay. So, and these are things we're still learning about, but when you look at the mechanisms of the signaling pathways that are going on in the intestinal hypertrophy, as long as you have an adequate common channel length, you're probably going to get very close in the same range. But you don't want to end up with too short of a common channel. That's to me the big key.
To me, the most important part of the surgery is the biliopancreatic limb. New papers show the biliopancreatic limb when you isolated the duodenum. Now we have the absorption of bile, and this is the key to bind the new receptors, and we have more metabolic effects. So what I've been here in Brazil is, if the patient is too much metabolic, it's better to put 100 centimeters as biliopancreatic limb. Another surgeon, better 150 or 200. But if you don't know how you have the total jejunum or the total small bowel, you don't know how would be the better.
I don't disagree with you, and it's probably a shortcut to not count it every time, but by not making my BP lim over 100, I have confidence that I'm not going to end up with too short of a common channel, which is my one big objective, is to not have too short of a common channel. So I may have a very long common channel, but at least I won't be too short. And I guess that's where I land. But
Winnie, let's move on to the next moderators.
Thank you.
Thank you so much, Dr. Teresa, for your insightful presentation and discussion. So now I would like to invite Dr. Nilton and Dr. Cordero for chairing the session 2.
Thank you.
Dr. Cordero, you can start.
Yeah. Well, the next presentation is about the gastric bypass, and Dr. Berends is going to present pouch size and limb length, what we have learned in the Netherlands. Please, Professor.
Let me share my screen with you. So there we go. It's very convenient that Teresa gave this wonderful presentation, and as this is a basic course, meant as a basic course for fellows, I try to focus on the theory about these limb length, and maybe we come to the subject of pouch volume and why it has come that we're doing what we're doing now. Once again, thanks for the invitation. As I mentioned, we're discussing limb length today, and I left out of the discussion for this moment the volume of the pouch, but we can come back to that later. Looking at the aspect of limb length, it's very worthwhile to realize why we're not talking about hypoabsorption or malabsorption so much anymore. And to answer this question, you could look at 4 aspects of hyperabsorption in Roux-en-y gastric bypass. First of all, something that's already mentioned, how long is the small bowel anyway? On average, according to Gray's Anatomy, it's around 5 meters. But there's a wide range in length, as you probably know as practicing surgeons. And extremes do exist, although you don't see them that often. But on average, there is, calculating a common channel of 2 meters, there is roughly 3 meters where you can construct your Roux-en-y gastric bypass from. So that's what you should keep in mind. Another question you could ask about hyperabsorption is, where does it actually take place? And that has to do with what we discussed just now. The roux can absorb some protein and vitamins, but the BP limb can't, because there's simply no food passing through there. And obviously your common channel can absorb almost everything. And it's good to know that this toll that Jesse and Higa and Maria talked about is the roux and common channel together. But the BP limb is totally irrelevant for calorie absorption. So how much does hyperabsorption contribute to your weight loss anyway? Well, there's several studies into that. This is an example of that. And what you do is measure calorie intake preoperatively before gastric bypass and measure it afterwards and compare that to what's excreted in stools, which you can measure just as well. And then you can calculate a function of your hypoabsorption compared to less eating. And in this study, they saw that 5 months after Roux-en-y gastric bypass surgery, less eating was far more important than hypoabsorption. As you can see, patients ate roughly 2,000 calories less than they did before surgery, and hyperabsorption was only a fraction of that. 40 months after surgery, you see a similar effect. People start eating a little bit more, which probably accounts for a little bit of weight regain, but hypoabsorption is still only 11% of the total amount of weight loss. Fourth question about hypoabsorption: can you reduce hypoabsorption by altering your limb length? Well, Teresa already answered that question. Not if your common channel stays longer than 200 centimeters. And we all know from other GI operations that if you, for some reason, have a very short small bowel, that small bowel adapts to the less calorie consumption, and it increases its absorption. Now, you shouldn't be too worried about creating these very short common channels in regular gastric bypass surgery. In this famous lab study, the longitudinal assessment study, in 500 patients, they didn't see any common channels below 3 meters. But still good to be aware of the fact that these short bowels do exist, and sometimes you stumble upon them. Altering roux limb for that reason does not give you a difference in absorption of calories, but if you make a BP limb longer, it does reduce your absorption of certain minerals that are absorbed in your proximal jejunum. To be complete about this common channel thing, of course you can make a very short common channel, which is sometimes done as Fobi did already 20 or 30 years ago in secondary surgery after failed primary gastric bypass, and obviously also in PPDs, in SADIs and stuff like that. But it's not the thing that you're talking about in primary gastric bypass procedures. I must point to a very recent article in the Annals of Surgery that gives you a very nice overview of what this distalization, real distalization of gastric bypass surgery means for weight loss after failed gastric banding. So in summary, the old thinking about absorption of calories after Roux-en-y gastric bypass surgery is false and is outdated. And the new goal should be not less absorption but eating less. And for that you need, as already is mentioned, some metabolic mechanisms that are very complicated. You could talk about gut-brain axis, gut hormones, bile acids, and L cells that go far beyond the basic thinking of constructing gastric bypass surgery. So instead of talking about hypoabsorption, it's maybe better to talk about eating less and metabolic change. To understand that concept, the hindgut theory is convenient, which simply states that the aim of your surgery is to deliver your food more distally in your small intestine. And that triggers a lot of mechanisms that have very difficult names, such as anorexia, incretin effect, and the ileal brake. But it all boils down to, in common language, less eating. And that's what we're all aiming for. Translating this to the construction of a Roux-en-y gastric bypass, it goes as follows. If you make this BP end longer, then the connecting part, which is your GE anastomosis, receives the food more distally, which is exactly what this hindgut theory says. And by the way, also your bile acids were already mentioned that are very important in this anorectic effect, also land more distally. You can understand from this that the length of your Roux limb is totally irrelevant to achieve this less eating. So making that longer doesn't add anything. But you don't have to take my word for it. It's extensively studied in many studies, one of which is this systematic review on 8 RCTs on the subjects that doesn't show any effect on BMI, or maybe, to be totally honest, a slight effect in BMI over 50. So the real question is not how to make your absorptive intestine longer, but what happens if your BP limb gets longer. And to study that, we did this trial starting in 2013 and published 2 years ago in obesity surgery, comparing in a randomized controlled trial 2 groups of one standard BP limb. And you can see that the BP limb in our standard procedure was already relatively long, and another long BP limb where the limbs were vice versa, were reversed. And you can also see that in both groups, the total of excluded intestine was roughly above 2 meters, just to exclude the possibility of different absorption in both groups. So they were on purposely kept the same. And these are the main outcomes, the excess weight loss results. You already could observe a difference after 3 months after surgery. And the gap widened up till 2 years after surgery with an excellent weight loss of 85% in the long BP limb group compared to 73%. And due to weight regain after 4 years, the difference decreased a little, but it was still significant after 4 years. But to be totally honest, looking at total weight loss as an outcome, we did see a significant difference after 2 years, but it disappeared after 4 years. And that has probably to do with the fact that we started with 75 patients in each group, but during follow-up we lost several patients, ending up with too few patients to reach statistical significance, which is called, as you probably know, a type 2 error in sample size. But that's still a difference there is very likely if you look at another study we did, very similar design, but then in redo surgery, doing gastric bypass after earlier failed bands. And there we did see, with fewer dropouts, a significant difference in total body weight loss after 4 years, excuse me. We also looked at glycemic control, though the studies were not powered for this, and we saw excellent results as is expected after gastric bypass surgery, 95 remission or improvement percent, and strikingly no new cases after 4 years. But there was no difference between these two groups. So they both did very well. We saw a small advantage in lipid profile in the long BP limb group, which probably has to do with resorption in this longer BP limb. And you probably know that if you have a longer BP limb, that bile acids are easily resorbed, and they have an inverse correlation with cholesterol and lipids. So a longer BP limb does better in that aspect. Overall conclusions of my talk on limb length is that a BP limb length of 1.50 m is the minimum that you probably should do. It does not give you more hyperabsorption, but it gives you significant improvement in excess weight loss. We didn't power for the other outcomes, so we didn't see any difference there. But if you could make the differences between the two groups larger, and remember that in the standard group, we already had a BP limb of 75 centimeters. But if you would have chosen the 40 centimeters, for example, or you would have compared a 2 meter BP limb, then you probably would have seen larger differences, maybe even in the other outcomes. This is only one study comparing BP limb length, but there are so many more, and this is a very recent article from Zerulia Nunez in SWORD last year that looked at 13 studies studying BP limb length, 12 of which showed an advantage in a longer BP limb. So maybe something for the really interested to take a look at. If you ask me what's the ideal limb length, the honest answer would be I'm not entirely sure, because it's not being studied in a scientific way. But my gut feeling says that your Roux limb shouldn't be shorter than, or shouldn't be that long. And maybe a real length of 50 or 60 centimeters, just to ensure that you have no reflux in your pouch, is sufficient, because it doesn't add anything to your weight loss. A longer BP limb does add to your weight loss, and could be as long as maybe 2.50 meters, although you will probably see a little bit more mineral deficiency. If you compensate for that, then you would be doing a good job. The only, let's say, the only trick would be how to maintain that weight loss. And then you come to the aspect of longer pouches and maybe putting bands around pouches. And your CC obviously shouldn't be less than 2 meters. Now, like Dr. Nilton measured, maybe it's wise to measure your small bowel if you have the strength for it to do that every operation, but it's probably a wise thing to do. So to start with the beginning question that Fobi asked us, why do still gastric bypass surgery in this day and age, where 80% of all procedures worldwide are sleeve gastrectomies? I think there's still an important role for a new and improved gastric bypass surgery, looking at limb length, looking at pouch size, looking at bands, because gastric bypass overall have better metabolic impact, better treatment of GERD, more durable weight loss than sleeves, and a long-term safety that is proven over 50 years, and it's reversible. So for me as a bariatric surgeon, and for most surgeons in the Netherlands still, the gastric bypass is still the gold standard. I think I'm guessing that 70 to 80% of procedures in the Netherlands are gastric bypasses. So if you do gastric bypass Roux-en-y type, then I hope in the future you can keep all these advices in mind. Thank you for your attention.
Nilton?
Hi. Nice presentation, Dr. Berends.
पोर्ट सब डाल के रख, पोर्ट सब डाल दे. नहीं पोर्ट डाल दे पूरे.
Go ahead, Nilton, you have any questions?
Yes. Dr. Berends, what about the measure the whole small bowel? Do you think to do in the future this measurement before to do choose the limb lengths?
You know, I probably should, but what we do not really know, neither in Roux-en-y gastric bypass nor in the mini bypass category. You know that Carabajo advocates measuring of taking a percentage of the total bowel length, which makes a lot of sense, and it also ensures that you never construct a very short common channel. But it also requires that every surgery you have to measure in these very overweight patients the whole bowel length, which in itself carries a certain risk for perforations and stuff like that. And it's also tedious work, to be totally honest. So yes, I think it would be a wise thing to do. If I'm prepared to do it every time, I'm not completely sure. Does that answer your question?
Yes, because I started measure because here in Brazil, since 5 years ago, I quit about bypass and I just do duodenal switch. But I call metabolic duodenal switch because I do a proportional intestinal deviation. And that's why I measure the whole.
But do you do switch as a primary procedure?
Yes, primary procedure. Even for patients with BMI 30, I do the duodenal switch, but I measure the whole small bowel and I put the 50% of the total small bowel as biliopancreatic limb and the 25 to 30% as common channel. Because biliopancreatic limb is very important as metabolic effect. The common channel is important about malabsorption, and the alimentary bowel is important regarding the reflux, because I have a sleeve in the duodenal switch. But the result is very, very good.
And I can imagine that it makes a lot of sense to take a percentage, knowing that the range in limb length, in small bowel length is so wide that it makes a lot of sense to measure your whole bowel and then take a percentage of the parts that you need. But to be totally honest, it is not studied, so we cannot know for sure. It's not studied, not in mini bypass nor in Roux-en-y gastric bypass. So there's no real answer to that. As for doing duodenal switch as a primary procedure, I do duodenal switches as well, but only as a salvage procedure after failed sleeve or stuff like that. I think the morbidity is a little bit too high to offer that to everyone, especially in BMI as low as 30. But that's very personal. Maybe in your hands, it's a very safe and good procedure.
Ramel, you have a hands up.
Yeah. So, Dr. Berends, can I just come in? So I have followed your elegance study. One of the reservations that we have is that whenever you increase the BP limb, you are shortening the alimentary limb. And so we do not know whether the benefit is only because of the lengthening of the BP limb or it's also because of the shortening of the Roux limb. There was a RCT done after your elegance study by Tower and group, and where they had a constant alimentary limb of 150 centimeters, and they changed BP limb from 70 centimeters to 120 centimeters, and they followed these patients for 5 years, and there had been no difference in terms of weight loss or metabolic effect. And there are many other studies which say that bypassing anything more than the jejunum doesn't change the weight loss. So most of the standard bypasses have an overall bypass of about 150 to 200 centimeters, which is the usual jejunal length in most of the patients. So how do you
I know. But to be honest, it's an historical measure to take for your alimentary limb. And you must realize that the time that I think it was Whitgrove thought of the Roux-en-y concept, it came from preventing reflux. So it was not about a metabolic influence on limb length, but they just took what was very usual as we do in treatment of gastric cancer, take 15 or 20 centimeters and then be done with it. So I'm not aware of the study that you're mentioning, but if I look at the Scandinavian groups, Neergaard and Gislason, they do even longer BP limbs of 2 meters and 2 meter 50. They have a very nice RCT on that, and they have exceptional good weight loss, up to 90%, which is even maintained after several years. After they have a 5 years follow-up, and it's far better than what we usually see in a standard gastric bypass that in most surgeries after 5 years has somewhere between 50 and 60% excess weight loss. And that's really a big difference. So it's not what we studied, and I have no proof of it, but I would go a little bit longer even than the 150 that we use. And I cannot think of any theoretical reason why you would, for any reason, make your elementary limb longer than 60 centimeters, because it doesn't help in any way.
Okay.
I'll move on to the surgery, Winnie, and then we'll have a panel discussion later.
Yeah.
Thank you so much, Dr. Frits, for such an excellent presentation. And we would now be moving to the operating room, where Dr. Bhandari will be presenting the live surgery case. Dr. Manoj Reddy, our consultant at the Mohit Bariatrics and Robotic Surgery Center, will be presenting the case details with you. Over to Dr. Manoj Reddy.
Hi everyone. I'll give you a brief history of the case we are about to operate. Patient is a 55-year-old male with a weight of 121 and a BMI of 42.3. He is a non-vegetarian, no addictions, and comorbidities include his hypertensive since 3 years, on drugs, and on type 2 diabetic mellitus since 5 years, on oral hypoglycemic medications, and he has an albumin of 4.2 and HbA1c of 7.33, which is poorly controlled with drugs. And viral markers such as HBsAg, HIV, and COVID-19 are negative, and ultrasound shows just grade 1 fatty hepatomegaly.
Thank you, Dr. Manoj, for the case details. I would like to invite Dr. Teresa and Dr. Frits for chairing this session. Over to Dr. Mohit Bhandari.
Okay, so thank you very much. Welcome, Teresa, and welcome, Frits. I think we are getting in for the first time in touch with both of you. So this is our operating room, and as Dr. Reddy gave you the history, we are starting first with an upper GI endoscopy. We do intraoperative endoscopy instead of preoperative endoscopies at our center, and this gives us the freedom of changing the procedure if there is anything untoward which does not permit a gastric bypass or a gastric sleeve. So this is the Z line. We can see we find mild esophagitis here, so that's okay. There is mild gastritis, as you can see, some little bit of patches here of gastritis, but that's not very significant. I go further. This is the pylorus, and this is the duodenum here. My intention would be to rule out any duodenal ulcer, which can cause problems, and if we do at all a gastric bypass in this case, I would not have the access to the remnant, so that can cause some issues. So while I come back, I pull the scope back, I see very clearly the duodenum, that I do not have ulcers there, and we can see that duodenum is fine. Except for mild duodenitis, I do not find anything significant here. This is again the pylorus. I pull my scope back, and then I see the hiatus. The hiatus looks good. We have some amount of gastric acid inside the fundus of the stomach, which I'm going to suck. That can also be taken care of by using a gastric calibration tube, but I'm going to suck this fluid, which is here, the little amount of gastric acid, and it's fine. I don't see any contraindication as far as this stomach is concerned for doing a gastric bypass. So I'm going to pull my scope out, and I'm going to start the gastric bypass. But this is a non-banded gastric bypass, the conventional one, and we know that patient has mild diabetes. And that's the reason why we have chosen this particular procedure. So let me first focus on the port position. Now just focus on the port position. So this is the optical port. We use a long Varus needle to create the pneumoperitoneum. This optical port is just supra-umbilical. We have a 12 mm port on side of the optical port in the anterior axillary line. On the left side, another 12 mm port on the right side in the anterior axillary line, but this time not exactly at the level of the optical port, but 2 finger breadths above. There are 2 5 mm ports, both on the left and on the right, both in the anterior axillary line, just in the subcostal area. So this is the subcostal margin here, and they are just 2 finger breadths below the subcostal margin. We have put an Athanson's liver retractor to retract the liver. So I'm standing on the right side of the patient. My assistant is standing between the legs of the patient. Now, let me take you through the laparoscopic view. Can we have the laparoscopic view, please? So looks good. First point is that I always see the hiatus, and I always make sure that whether we'll be able to do anything for this patient at this stage. So hiatus is good. I could confirm that by endoscopy. The first step in the gastric bypass is just to pull all this omentum back and divide this omentum so that we do not have any pressure while we do this anastomosis. We usually do a anticolic, anti-gastric anastomosis. So, which makes it very important that we divide all this omentum. I would usually start to divide it just below the falciform ligament because we need some landmark to decide as to where we should divide. So this division is being done, and I, for one reason, do not come very, very close to the transverse colon. When I, do this division, I remain at least 4 to 5 centimeters away, like I'm doing it now, from the transverse colon, because I don't feel the need to, go extremely close to the transverse colon to denude it by the greater omentum. It's just that we don't want pressure over the omentum, so just removing it a little bit away from the site. So that's the transverse colon there down. I'm going to remain a little bit away from that to avoid any injury to the colon. So this division is done exactly parallel to the falciform ligament. And then we go towards the left subcostal area. So the extent is just done in a way so that the pressure on the loop is reduced when we are performing the anastomosis, and that's it. So
can I ask you a question during the procedure?
Yes, absolutely.
Yeah? Okay.
You're free to ask any questions. I would love that.
We looked very critically at our process of doing gastric bypass surgery, also in order to save time. And I think on average, most of our procedures are below 45 minutes now. One of the things that we save time on is not dividing the omentum, which is at least in 2/3 of the procedure not really necessary, because we do not see an increase in any leakage or traction on the anastomosis. Do you think that you could leave that out?
Well, I have left it in some of the cases where we have patients of lower BMIs. In Asia, we do a lot of these low BMI diabetics where we don't require it. But my technique is such that I need to divide it just to avoid some pressure, because we do not do a loop gastroenterostomy like most other surgeons do. We do a end Roux gastroenterostomy, which makes it convenient for us to sort of divide that. It takes around 2 to 5 minutes in all my series to, divide the omentum and perform a gastric bypass. So I just do it when I'm dealing with patients like as this. So this is my answer to your question. This is the ligament of Frits, and I don't find the inferior mesenteric vein here because of a lot of fat, but I'm sure this is the one. I'm going to just count here 10, 20, 30, 40, 50, 60, 70, and 80. So we, we are not very aggressive with our limb lengths in gastric bypass. Is just the 80 centimeters of a limb length which we follow. Also, a point which I wanted to make is that I have heard surgeons saying that they do not perform intraoperative endoscopy because the bowel, the small bowel gets dilated, whereas you can see here that the small bowel is not dilated. So, that theory that you cannot do an intraoperative endoscopy just because the small bowel gets dilated in that process, it does not hold true. You can see here that we are easily able to work on the small bowel despite doing an intraoperative endoscopy. So that's the beauty of the technique. We have to push minimal air. Now this is the BP limb, which I'm gonna keep it separately. I'll mark this BP limb just for the sake, because it's a teaching case. I'm gonna mark this with a clip, and my elementary limb won't have the clip. So the BP limb is just marked here. It's around 80 centimeters. I'm not gonna go beyond 80. I agree with Teresa's concept of taking the elementary limb as around 100 and 110. So this is 40, 50, 60, and I can even count it just by using the grasper. So this is my length which I'm counting, but 70, 80, 90, 100, 110. So that's the routine length of the BP limb for us, which we usually would take. And I would not take it at a 60 or 50 centimeters. I know why that thing came into the practice, because I think the publications have suggested that most of these BP limbs which are less than, most of the elementary limbs which are more than 50 centimeters are good enough to sort of prevent the bile reflux, and that's why this theory came in. So this is my elementary limb. I can follow it up till here. So let's follow this so that we are sure that we made an enterotomy. This is how I counted, and that's the enterotomy. This is the common channel here. This was the limb which I marked with the clip. So this is going to be my BP limb, just for the sake of teaching case. We conventionally, now we can remove the clip, and then we can do a enterotomy here into the BP limb. So I usually make my enterotomies here at the corner because we use a technique where we can close this defect with a stapler. We can also do the same by using a hand sewn technique. So I can demonstrate both. Whatever it is, it usually requires minimal time when we use a staple technique as compared to a hand sewn. So, but both of them are good and secure technique, whatever the surgeon would prefer as far as he's concerned. So this is the BP limb being anastomosed with the elementary, and this common channel, irrespective of what we do, we usually keep the same limbs, the 60 to 80 centimeters of a BP limb and the 100 to 110 centimeters of the elementary in primary cases. So we do not calculate the entire common channel. I have never done in more than 4,000 gastric bypasses we have operated. In revisions, we do the entire calculation. So that's important, that if we are revising, we calculate the length of the entire bowel, but not in the primary cases. Also in revisions, we are more aggressive with our limb lengths. So that's the reason why we have to take into consideration, with more malabsorption. We need to take into consideration the fact that it can disturb the proteins and multivitamins in as far as the procedure is concerned. So we would be more cautious there and calculate the entire common channel. Now this is what I'm doing is an important step. This is the Brolin entry obstruction stitch. So we know that this is the elementary limb, that's the BP limb, and this is the common channel there. Now we just want that there should be no twist like that. So I'm just taking the Brolin's anti-obstruction stitch. This is important because we did a stapled anastomosis. Usually when I would do a hand-sewn closure, the anatomy is not that twisted or prone to being twisted. So this is what we want. We do not want this to twist. So this is the common channel here. That's the elementary limb. And that's my anti-obstruction Brolin stitch. Now we have a large internal hernia defect. So you can see that this all can herniate, and obviously there's no doubt that we're going to close it. I'm using here the endostitch device. My first 1,000 odd gastric bypasses were done by using the conventional suturing, but then as Frits said, the time under 40 minutes of a gastric bypass, it's important because time under anesthesia, and I agree with Frits, and specifically with high volume centers, we realize that this time under anesthesia is very crucial. So if you keep on doing a gastric bypass for more than 2 hours, the results can be a little different as compared to a 40 minutes of gastric bypass over time. So we started doing this as saving some time because the endostitch can come really handy. So this is the internal hernia defect. I'm going to use this non-absorbable suture. So this is actually Ethibond. We have used Prolene here. We use silk. My experience with Ethibond to close the internal hernia defect has been fabulous. This is a very nice suture, almost negligible issues in terms of handling it. So the handling of the suture is very perfect. And as you can see that this technique of not going too deep to hit a vessel and not going too shallow to break through the momentum is just creating some good adhesions which remain there for a pretty long time. We need them for lifelong, so that, and the point here is that we do not end up creating micro defects, because we create defects which create adhesions. We create suturing which create adhesions and not micro defects is what we aim for. So that's the end here. I'm gonna stop my closure. I think I closed it in entirety, whatever I could to create those adhesions as I mentioned, and they're gonna help me avoid an internal hernia as far as possible. I cannot say that it's a 100% chance, but yes, it's. So this is again the common channel, the BP limb. A good recap, this is the elementary limb, and we're gonna trace back this elementary limb back. So you see, we trace it back here, and then we follow this, and this is the final elementary limb which is gonna go and get anastomosed with the gastric pouch which we're gonna create. So that's the elementary limb. I'm not gonna mark it here because that's the only limb which remains, but I'm gonna demonstrate the internal hernia. So the mesenteric space between the two defects here, I think that's closed. So this is a closure of the defect. This is the elementary limb, the common channel, and the BP limb. Now we're gonna go up, create a pouch before we start the anastomosis. So now you can see that I started my division, and why I was telling to Frits that that's important for me, because this limb with that kind of momentum gets lesser pressure as we have all removed that. It's the same location where this limb is gonna come up. So that it gives a little bit of ease for me to sort of bring that loop. Although surgeons performing loop gastroenterostomy can change the way they bring the loop, so they can start from here. So they can start from here maybe. If they don't feel it's coming, they can go back down there and start from here. So they don't need to divide that loop, but with my kind of technique, I'm more confident by dividing it. Now we follow a perigastric, a pars flexura technique, pardon me, to make the gastric pouch. I know there's a lot of debate in the function of the vagus nerve, and vagotomy at this in this area is considered by some to decrease the gastric evacuation. The proponents would say that it causes less marginal ulcers. There's no consensus on that, but we have been following this technique of pars flexura. It's more simple to adopt to rather than doing a perigastric technique. It's a little faster. This is a small vessel we need to take care of, and the way to take care of is to buzz it on both the ends, and then we can even cut it. So that's it. We have this gastric pouch here. I'm just going to take care of small vessels which bleed while we fire the stapler. So my landmark to fire the first stapler is close to the left gastric pedicle, because I make a little longer pouch as compared to most other surgeons who do a gastric bypass. And that we do because we usually were doing banded gastric bypass before. More of them were banded. Now we have almost a 50% rate of banded and non-banded. Because more banded gastric bypasses were done, our pouch size was a little longer as compared to what most surgeons would make. I'm going to measure it at the end of the procedure, the entire anatomy. So this is my first firing. I'm going to make a horizontal fire here. So that's the horizontal fire. And then we're going to call the gastric tube. We use a size of the tube which is 38 French. In India, that's the size which is available. So we use the same size here. And that.
Excuse me, Mohit. Can I for a second come back to dividing the whole of the smaller momentum there and at the smaller curvature side, because it is the first time I see that. I would expect that you theoretically you do a complete transection of the vagal nerve, right?
I think it's not complete. I think it's partial vagotomy. Complete would be if I go very close to the left gastric pedicle and then divide it. So that would be complete vagotomy, but this is not complete. This would be probably, because I'm not touching the hepatic branches there, it's partial vagotomy which we do. But as I said, we can debate on that, but I think this is the same technique which probably Phil Shower uses, and many other surgeons who do a pars flexida, and they all do a partial vagotomy. Push the tube, please.
Okay. I would have guessed that it would give you more diarrhea in the end if you look at the
so
larger.
I thought so, Frits. I thought so that it's going to give me more diarrhea. Let me tell you, I have a 70% rate of constipation in most of my gastric bypass patients.
Okay.
And I have no patient complaining of diarrhea after gastric bypass. In fact, they want some to happen. You know, I started doing a mini gastric bypass, and I always thought that you know, a mini gastric bypass would cause a lot of diarrhea. Believe me, I've started doing a 180 centimeter of a BP limb, and you know, as Dr. Goel was mentioning, that we have become more and more aggressive with the bypass and less with the mini bypass. Now I even have constipation with my mini bypass patients. So yeah, you know, it's interesting. We feel that we would see that, but we don't see diarrhea even with this kind of vagotomy. I heard, push the bougie, I heard Phil Shower saying that they have lesser marginal ulcers when they compared it with other surgeons at Cleveland Clinic who used to do a perigastric, but we don't see, because I think Dr. Fobi does a perigastric at our center, and I for sure do a pars flexida, and we don't see the difference between the rate of marginal ulcers at our center.
And I'll just throw in my experience too, because I used to do a perigastric and now I do pars flaccida technique, and I hesitated for a long time, but I found that it is easier, it's faster, and you do a partial vagotomy, but you don't see the effects that you would anticipate from that. And we haven't seen higher marginal ulcers doing the pars flaccida technique. So I think a lot of the theoretical concerns early haven't panned out, and a lot of surgeons certainly have switched to a pars flaccida technique.
I was doing this and demonstrating it live to Dr. Higa, and he said something which I would want to ask everybody. He said that think about the surgeon coming next. If you do a pars flexida, the anatomy is more disturbed, but you know, the point here is that what is the rate of revision after a gastric bypass? I'm not seeing much. You know, I'm seeing a lot of revisions after a sleeve. I'm not seeing that high rate of revision. So I kind of bend more towards the pars flexida, like what Teresa said. It's easier when you have fellows. It's easier for them to follow. they are more confident, because perigastric, if they have a, God forbid, a bleed from the perigastric vessels, it makes the job much difficult. Now, let's focus on the anastomosis here, and then we can get back to that discussion about perigastric or pars flexida. So I'm going to take a 3 centimeters, around 2.5 to 3 centimeters of an anastomosis here, and I don't go up 1.5 or 2, or because I feel that's a little bit too much for the patient, because we use a technique which buries a lot of this omentum inside, a lot of this gastric tissue inside, pardon me, and that causes some sort of you can say a little decrease in the size of our anastomosis, which is usually there. So what we prefer is to do around 2.5 to 3, and then later on maybe we can adjust it by the suturing we do, because the technique which I use, that suturing causes a little bit more reduction of the anastomosis, as I can see now. This bleeder can be easily tackled by using this suture, and that's the best way of dealing with it. I usually take a conal suture here. So the conal suture can control this bleeding in a more effective way than anything else. So what I do usually is that I took a stitch from inside the anastomosis, and then I came outside, and now I can take a stitch here so as to prevent the bleeding and the leak from the sides. I'm going to make the anatomy a little more clear once I take this bite, so that I can prevent the bleeding. Now I can clean it and I can demonstrate as to what I'm trying to do. So I took a stitch inside. That stitch was taken from the base of the anastomosis, not actually decreasing the size of the anastomosis, but just from the base. And I can see that there is a little bit of oozing there, which is happening. So I'm going to just use my suction to just see the point, and I can buzz it with a bipolar cautery, or maybe use a harmonic if it's required. But the point I wanted to make was a conal suture. So we took a conal suture here, where I took the first stitch from the base of the anastomosis, went outside, came inside again, just like when we do secure these corners. So it looks okay for now. I think I sort of controlled the bleeding, and now I can start to suture. So what we do is we take a series of 2 conal suture to secure this corner. And the benefit of doing this is that now I'm able to see the corners much more clearly. So this is the corner which I have secured, and that's the caudal end of my anastomosis. I'm going to take another bite here so that I further secure the caudal end of my anastomosis. That's it. At this stage, I can cut my suture here. So I have secured this corner, and you can see that it was oozing a little bit because there was a gastric vein, and now it has stopped completely. And this is, can you focus on the corner, please? You can see that this corner looks okay. I have completely secured it, and I'm not going to cut it. And now what I have is something here, which is my cephalad end. There are 2 ways of doing it. I could go inside the anastomosis and bring the endo stitch out, the needle out through the anastomosis, or I can go beyond the gastrotomy and enterotomy site and take a suture just like what I did now. So I'm actually around 2 centimeters to 2.5 centimeters away from the gastrotomy and enterotomy complex. You can see here, that's the gastrotomy enterotomy area, and I'm at least 2 centimeters away from that. So I'm sure that I do not leave that area which is open without taking good sutures from that place, and do not give rise to an anterior leak. So this holding this suture gives me the advantage of triangulating, because the entire procedure is being performed standing on the right side of the patient. So the endo stitch also provides some advantage, plus I can take the anatomy anywhere. I can take it here, I can take it there, and just twist it to my own convenience. These are the full thickness layers which we take. I usually would use an absorbable suture, and this is a single layer anastomosis. So this is a suture is known as polysorb by the Medtronic, and this polysorb is akin to the vicryl in laparoscopic surgery and open surgery. So as you can see that I'm taking good bites on both the ends. Using the staple line to make the anterior wall of the anastomosis is something which is not done by many surgeons, but we do it because it gives a good protection for me to take the sutures. So you can see that this is this is a single layer anastomosis which I performed. We don't take 2 or 3 layers, and this technique was the original Phil Shower's technique, where they used to take 4 layers, but now most of his fellows also stopped doing that. So I'm here. I have reached the caudal end, which I secured, and now I can sort of take 2 or 3 good throws of surgical knots at the caudal end. So this ends my anastomosis. I'm going to come in with an endoscope just to demonstrate how this anatomy looks inside. And we're also going to calibrate the length of the pouch, the breadth of the pouch, the length of the anastomosis, and also how it looks from inside. But before even we start to do that, I'm going to just clean this area a little bit. And once I clean it, I can see that there is no oozing there. Everything looks fine. I'm first going to close the Peterson space, but let's measure the length of this pouch before we close the Peterson space. So we can see this is a ruler scale, which I often use, and Dr. Fobi would ask all our fellows to measure everything we do. So you can see the length of our pouch is around 6.5 centimeters. The breadth of our pouch calibrated over the 38 French bougie is around 2.5. Can say it's 2 centimeters. I would say it's 2 centimeters. And then if we see the length of our anastomosis, what it looks 2 centimeters from here. Obviously, we took 2.5, but it would be less than 2, would be around 2, but less than 2.5, because obviously we did some suturing, which causes some edema, the mucosal edema and some serosal burying all around. Now, this is the Peterson space. And as you can see, this space also has the potential of giving rise to an internal hernia. So I obviously going to close it, and we close it in all our cases. So the base is the most important area. It is more technically challenging to close a defect when we are doing a retrocolic anastomosis, and I do retrocolic in some of these cases where we have a lot of this omental fat. Although I stopped doing retrocolic because it's much difficult to revise those gastric bypasses. Now mostly doing anticolic, they're more simple, and these defects are easier for our fellows to close. You know, I believe that the most important first step, even before closing these defects, is to demonstrate these defects. So the way to demonstrate them effectively is to make the patient's position supine. Once the patient is supine, or maybe you can go for a little bit of head down, and then turn over the omentum and the transverse colon like I did. So this helps me to expose the defect. Only then I can close it. So you can see, just show my hands how I am. So you can see that I'm holding this back, the entire transverse colon here, so that I can expose the defect. So once I have exposed this defect, then the closure becomes much easier, because if it keeps on falling continuously, the closure of the Peterson space is almost a difficult task to accomplish. So that's it. I'll again demonstrate. If I closed it effectively and do not create micro defects, so do more damage than doing a good. So this is the defect, and you can see it's nicely closed completely. And now I'm going to come in with an endoscope to demonstrate you the anatomy from inside. The gastric bypass is complete. So let's have my anesthetist help me to put the scope inside. Can you focus on the endoscopic view, please? And keep the laparoscopic view in the PIP. So I'm again going to go inside. I expect a little bit of oozing inside. Even before doing it, I would ask my assistant to just sort of block the passage so that we do not have a lot of distension with the gas going in. This is the esophagus. Here is the G junction, the Z line. As I said, I expected a little bit of oozing, but it's all clotted blood. I'm going to push a little bit of air very slowly. This is a newly made anastomosis, so I'm not going to force anything inside, because gastric bypass is a small anastomosis, and as you can see that I'm inside, I can. So this is what we have. We have a nice view. You can see that it's all blocked. I can just put a little bit of water so you can see that this is the nice passageway. I pull. Now the best thing to visualize this is while pulling it back. So I pull this back a little. This is my anastomosis. It looks okay. It doesn't bleed that much now. It looks fine. I'm going to pull my scope back. Now let me measure my length of the pouch through my scope. So you can see my anastomosis is good. It's around 2 centimeters. It's snug with my scope. Now I can measure the length of my pouch with my scope. So I pull this. I start from here. So it's around 48. And now I'm going to pull back, 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 back. And that's my Z line. It's I would say around 44, 43. So that's it. I'm going to suck this air.
Mohit, do you ever in this phase see an active bleeding on the inside?
Yeah, this active bleeding which I see inside, I think it's going to be fine. You're talking about this, right?
Yeah. No. It's not in this case. But do you ever see blood pouring out?
Oh, okay.
And then do you treat it right away?
So if I see a spurter inside, I have seen, yes. So if I see a spurter inside, if for example I have a spurter which is bleeding, and I so there are two things which has happened in past. I see a spurter, I go and I can do two things. Either I can do a spray. So there's a flow seal which comes with an applicator. You can go and spray. I can clip it at the base. That's also possible. Plus, if I do not have both the clip applicator or the flow seal device, I can actually go inside, put in a scope, and take some sutures from the spurter if I can control the spurter. At most times, the spurter would be either from the staple line, which can be easily managed by the suturing. But if it is from the anastomosis, that's the trickiest one, because we know that blue load is good for the gastric mucosa, but it's a little bit too much for the intestinal mucosa, which we usually would prefer a tan if you're using a Medtronic, or a white reload if you're using a J&J. So I think that's the site of the bleeding. I would go and manage it. So three things, as I said: you can apply a flow seal, you can do some pressure tamponading, you can go and put a clip at the base. And for once I was there with Dr. Fobi, and we tied, because we do a lot of these endoscopic sleeves. So we did a full thickness suturing through an endoscope by a double lumen endoscope. So I have tried all these things, and most times they work. Also, sometimes the blood pressure is a bit too high, and if that being controlled with some pressure tamponade, most of the times we find that the problems are solved.
Yeah. The blood pressure being too high is hardly ever a problem. It's more that you're not aware that it is sometimes too low at the end of the procedure, and that's where the problems start.
Yes. So what we usually do for our sleeves, I haven't had this problem in sleeves, but in bypasses, but with sleeves we usually would extubate our patient with a blood pressure of 140 by 90 mm of AGO by 80 mm.
Yeah.
We won't call it a day until it's 140, because I think sleeves and mini gastric bypasses have long lines which are more exposed to bleeding than a gastric bypass.
Yeah, same here. Yeah.
So our most common complication with more than 4,000 mini gastric bypass has been the bleeds, which has happened. So we are very concerned about the bleeds. Not much with a gastric bypass, but yes, with sleeves and MGBs, we are very concerned. So we raise the blood pressure, remove the gastric calibration tube, because sometimes tube can cause some pressure and avoid bleeding to be visualized. So that's it.
Exactly.
So thank you very much. We had some short time because we are running late. I'll just shift to the studio for the panel discussion. Thank you, Frits. Thank you, Teresa. You were great moderators, and I hope you enjoyed it. Thank you.
Excellent, Mohit. Thank you so much.
Excellent procedure.
We're
So-
moving. Go ahead.
Would you like me to comment, or you want to just go ahead?
No, you go ahead, please. We want to comment.
Okay, so I was going to hopefully ask him a few questions, but there are a few things that I do a little differently. We all have our own techniques. One thing that we talk about for endoscopy, and there's a whole discussion we can have about pre-op endoscopy separately, but for me, if I had seen that on endoscopy, I would treat that patient pre-surgery, especially for a bypass, because we feel that for me, that would have been moderate to severe gastritis with erosions, erosive gastritis. And we would have treated him pre-surgery with PPI to decrease risk of marginal ulcers, because especially in the US, a lot of surgeons, marginal ulcer is the bane of our existence. I think it's highly underreported. We treat it, it requires multiple endoscopies a lot of times, and they're always patients you inherited, not yours, but we need to do what we can to prevent that. So for me, we actually start patients on a PPI before surgery. So I used to do pre-op endoscopy on everybody, then I went to selective, now we're kind of swinging back. But we saw so much gastritis pre-surgery, especially when we started doing sleeves, that we started to say, you know, these patients have inflammatory disease. The majority of them have gastritis pre-surgery. It's just a matter of how severe it is. So we started a PPI at least 2 weeks ahead of surgery to help improve the tissue quality coming into surgery for both sleeves and bypasses, and we saw a benefit. And then we keep them on a PPI for 6 months afterwards as well. But so that would be one thing that I was going to talk about. Another thing is I do use CO2 insufflation, and I do endoscopy during the procedure as well. And so I think with the CO2 insufflation, there's less risk of bowel dilation, but I do occlude the bowel, as he demonstrated a little bit later. But I use high air pressure on my anastomosis on purpose, because if it's going to leak, if it's going to show bubbles, if it's going to bleed, I want to see it right now where I can take care of it. So I stress it very hard because the patient is going to stress it. And we can say we're going to control the blood pressure, but you know what? They get in the recovery room, things happen, the blood pressure goes up. So I actually want to see it when it's under stress in the operating room. So there were just a couple questions or comments that I had, but it was a great procedure, great to see.
Since you mentioned that, what is the difference in treating the gastritis preoperatively? If you're going to keep them, if you see the gastritis and you're going to put the patients on PPI, at least in our indoor, we've not seen any patients having any adverse effect because they had surgery or gastritis in place. But our feelings were that you're going to treat the gastritis anyway with PPI, and we normally keep the patients on PPI for 6 months to a year and sometimes longer. So what difference does it make? You're just prolonging, you're putting another obstacle to the patient having surgery by waiting 3 weeks or 6 weeks.
Yeah, so especially for more severe gastritis, I think it does have an impact on the tissue quality, on the risk for complications. Even for sleeves especially, it changes the thickness of the tissue and it changes how they feel post-operatively. So we find that definitely all patients have some sensation of gastritis within 2 to 6 weeks post-op just from the surgical procedure. But if they had it pre-surgery, and especially if it was untreated, the symptoms are pretty significant. And then I think some surgeons interpret that as reflux, but it's really not. As you ask them more about it, it's definitely gastritis, horizontal, not vertical. And it does heal with PPI, but oftentimes then we'll bump it up higher. So if we see gastritis, we'll use a higher dose of a PPI, and then we may add an H2 or we may add other agents as well. So that's, again, been an evolution over time, but I do think that it improves things pre-surgery and post-surgery for our patients.
Can I make
but
a
it's
point?
A good question.
Can I make a point?
Go ahead.
Yeah, so I have done endoscopic sleeves because we do these procedures. So I did endoscopic sleeves on patients with severe gastritis. And the same we do in patients who do not have gastritis. We do not see different rate of bleeding while we take sutures through the gastritis stomach which has gastritis. I haven't seen that. There are 3 cases where we thought we should abandon the procedure, and Manuel was there with me, and I said, let's abandon. So he said, no, you can go on suturing it. It did not bleed more than what it would have bled in fact, most of the bleeds I have had doing endoscopic sleeves while I take full thickness sutures were through normal stomach. So I kind of agree with Dr. Fobi that we are creating one more predicament for a patient to first take this treatment for at least for a year, and then, you know, he gets screened for H. pylori, and then he gets that treatment. And then this is another problem which I agree that if we have very severe gastritis, a sleeve probably could be a better option, because that gives us an option to sort of completely scope that area. But to postpone that case and keep it for PPIs for 6 months is another problem, which we unfortunately we don't declare. Duodenal ulcers, yes. A large gastric ulcer which is infected at the base, yes, but not for mild and moderate gastritis.
Yeah, and we don't delay them for 6 months, so I didn't want to give that impression. But if it was very severe, it may be 6 weeks and then repeat the endoscopy. If it's less severe, we'd still treat it ahead of time, but we're not going to delay 6 months. We're talking probably more in the range of 6 weeks. And even during that time, we're preparing them in other ways. So usually it doesn't delay their total time to surgery much at all.
Dr. Lamasters, do you do your own pre-op endoscopies?
I do for the majority, but honestly, my practice is too busy. I don't have the time. So some of mine are done by GI, some of them are done by myself.
So you do have privileges to do both.
Yes.
Frits, what about you? What about in the Netherlands? Are surgeons allowed to do endoscopies? And do you do one?
Yeah, allowed to do so. And although nowadays most are done by GI surgeons, but there's no general rule in the Netherlands to do one before surgery, and there's very little proof that it adds anything to the procedure. So in general, it's left out here. So on more than 1,000 procedures a year that I do, I never do a gastroscopy in advance, unless there are severe complaints of gastritis or reflux or stuff like that. And on occasion, you stumble upon a big hiatal hernia or something like that, and we simply accept that. But the added morbidity and, as you mentioned, the obstacle of gastroscopies in advance doesn't help in achieving your goals. So I know it's a big discussion, especially if you have liability issues such as in the United States, but we simply don't have those, and there's not a lot of proof. I know there are so-called pre-malignant things to diagnose in normal gastric patients, but the percentage of those is so low that it hardly makes your preoperative endoscopy worthwhile. So we just leave it at.
Dr. Nilton, Kawahar, what about you in Brazil? Do you do pre-op endoscopies? And if so, who does it? Do you do it? Or?
Yes, hi. Yes, well, here in Brazil is mandatory to do endoscopy pre-op. And I have 2,500 cases, and in 2 cases I diagnosed pre-malignant disease in the stomach. But here in Brazil it's mandatory. And the difference from, I think, the United States is the price, because endoscopy here is like $100, and in the United States I think is like $700. $100.
Okay.
Yeah.
Everything's better in America.
Well, are you doing your own pre-op endoscopies now in Mumbai, or is it done by a gastroenterologist?
So, Dr. Fobi, I've been doing it for almost 30 years myself, and I do it mandatorily in every patient. But I agree with you, so many times when patient is asymptomatic, we do it on the table, on the operating table, just like how Mohit did today, and we don't wait. But what we do differently is we always take a biopsy for H. pylori. And if H. pylori is positive, we eradicate it after surgery. So because, in a bypass patient, we will never have that opportunity to know whether H. pylori was positive. So I think otherwise it's the same as Mohit did, routine pre-op endoscopy in every patient.
Wouldn't it be easier to do a different measurement of your Helicobacter, for example, through serology or through breath testing?
We don't do serological, so we do only through the endoscopic way. And I agree with Dr. Kawahara. We actually diagnosed the patient with the malignancy, asymptomatic patient with malignancy, and generally the tumor rates are around 2%. They are mostly benign. They are about 2% so I think we are very, very emphatic that endoscopy must be done before a bariatric.
And
Dr.
to your
Cordero,
question, Dr.
Go ahead, Teresa.
I was just going to say to Dr. Berends that we do a breath test for H. pylori because it is not 100% preoperative endoscopy, but for bypass patients it is, but definitely not for sleeves. So,
Makes sense.
Dr. Rafael Cordero, what do you see from these young surgeons? Anything you have to advise looking at the way they do surgery not different from what you and I did? Rafael? Okay, I hope he's still on.
Okay, that's okay. Do you listen to me? Yes.
Yeah, we're just asking you.
Oh yeah.
In
Mexico,
young surgeons doing anything different, or do you have any advice for all of us?
No, what we saw was a superb example of a good surgery, and also two conferences excellent in order to educate people. And I congratulate you for this virtual bariatric university. I only have two comments about this. From the surgical or from the scientific point, this is excellent way to educate people. From the statistically, I think the presentations of Teresa and Frits were excellent. And from the philosophical point of view, we cannot forget that the ideal, as Don Quixote says, is an impossible dream. So we will never get what we intended to do. It is excellent to have every day the purpose of have a perfect operation. And that's why we tried one and another technique, another modification. And since I met you 50 years ago, I think that the basic purpose is to offer the best for every patient. So I congratulate again and all the panelists because this has been an extraordinary experience.
Dr. Bhandari, do you have any questions from the audience, or do you have remarks for the panel?
No, I think I'm good. I think great presentations both by Teresa and Frits, and learned a lot. I have no other comments. I think if there are any questions, Himanshu, do we have some questions from the audience so I can take them? So there are no questions from the audience. Dr. Fobi, we can make the closing remarks.
Well, just want to thank the faculty. We know you've taken time from your busy practice to join us. Fellows appreciate this, and the other surgeons who join in on LinkedIn, Facebook, and whatever media that exists currently. If you have any questions and you send them in, we'll respond to you in writing by email. Really, what do we have for next week?
So,
thank you all.
So we have the banded gastric bypass for the next week, and we have another set of faculty members. So we can play the promo there, short one. Yeah.
Can't hear anything.
Just making it live, I think so. And now can you see it?
Yeah.
Okay, so that's the episode 6. That's gonna be on the banded gastric bypass.
Ya que se acabó ahorita.
So we welcome all of you on 2nd of November, and that's going to be an interesting event. Another one on banded gastric bypass.
Thank you all faculty members. Thank you,
you.
Dr. Bhandari,
Thank
and your
you.
staff and the audiovisual staff for putting this together. And we see you all next week. Namaste.
Thank you. Thank you.
Thank you.
Thank you so much.
Thank you,
Thank
Dr. Fobi.
Thank you.
Bye-bye.